Just like with the shoulder, these maneuvers can be used to assess and then also to treat either with muscle energy or with articulatory technique. For today, we're going to focus on muscle energy as a treatment option. So the steps for the hip Spencer technique start off with flexion. So the first step would be to get control of the lower extremity and then check the hip up into flexion. So like before when we were talking about pelvis dysfunction, you don't want to take the knee all the way up to the shoulder because you're going to go right past hip motion where the pelvis is going to start to rotate. And so we want to move just until we start to feel that we're at the end of femoral motion in the acetabulum. So flexion is going to be right here. The next step is, from here, if you felt restriction in flexion, you could have the patient push down into you for 3 to 5 seconds and then relax and try to treat it with muscle energy. After hip flexion comes hip extension. Here we would want to drop the knee off the table and check hip extension. If the patient's foot hits the floor like this, you would need to either raise the table or pick their ankle up so that they don't hit their heel on the floor so you can get all the way to extension. And similarly, you could turn this into muscle energy by having the patient push up and then relax and do 3 to 5 cycles of that. Next up is circumduction. Here you want to grab a hold of the knee and you're going to do circumduction of the hip in both directions, both clockwise and counterclockwise. And you're looking for any restrictions in terms of range of motion that you might see in the hip. And then after you've completed that, your next two pairings are internal and external rotation. So with the with the hip flexed up to 90 degrees, internal rotation is going to look like this, and external rotation is going to look like this. All right. You want to be careful if patients have knee problems that you're not putting too much torque on the medial or lateral aspect of the knee, and that it's really the hip that is doing the internal and external rotation. So that's going to take some care to make sure that you're being mindful of the patient's knee. And then finally, the last two are abduction and adduction. So from here, abduction is going to be coming straight across. And if you see what's happening here, again, the knee will come across into adduction, but if I continue to go, his whole pelvis will rise up off the table, and then his lumbars will start to rotate if we keep going. So we don't want to get all of that. We just want to get to the edge of what his hip will allow before here where his pelvis is starting to come off the table. So that much is your adduction, and then coming straight out to the side is your abduction. And here, to a lesser extent, the same rule applies. If I keep pushing him, his opposite pelvis will start to rise up off the table. So we want to stop before we get to here where the pelvis is starting to move, just to the edge of what his motion can allow. And with either of these, again, you can turn this into muscle energy technique if you choose.